I want to welcome everybody to this week's happy hour. A couple of announcements. As I was talking to April McDonald, wanted to let everybody know, those who are on the call now and those who might be watching later, that on September 23rd, we're going to be hosting an informational seminar about the subspecialty of dermatopathology. So if you've ever thought about applying for a fellowship or want to know a little bit more about career options should you pursue that training, make sure that you tune in. It'll be a virtual informational seminar starting at 5 p.m. On September 23rd. That's a Thursday. We will be recording it and posting it to the YouTube site. And we would encourage you to submit questions to our educational site, education@sagesdx.com, in advance of the seminar so that we can make sure that we get the questions sent out to the appropriate panelist. We'll also be taking live questions via our chat. So today we're going to try something a little bit different, based largely upon the feedback that we've received from residents. The interest was in trying to vary the length of some of our unknown sessions. You know, sometimes you might only have 20 minutes, sometimes you might have 45 minutes. So from time to time, we'll be altering the number of cases that we throw out and the length of the discussion. So I'm going to try and get through these 6 cases in 20 minutes or so, and we'll see where it takes us. As always, you can, I've got my chat up. You can submit any questions that you have via the chat. I'll check it from time to time. If perchance I miss it, you can email any questions that you have to me at tdavis@sagesdx.com. Or you can email education@sagesdx.com or text me 210-416-4815. So let's go ahead and get started. Our first case, case number 1, the correct diagnosis was a deep dermatofibroma. And I've got 2 slides on the screen now. We're going to focus initially on the piece bisected puncture on the left, because that was the specimen you had available for review. And even at scanning magnification, one could see that we've got a dense kind of nodular infiltrate within the dermis, fairly sharply circumscribed, but the borders are not real smooth. The epidermis overlying this lesion is hyperplastic with elongation of the reedy ridges. There is an increased amount of melanin pigment within basilar keratinocytes, and many of the reedy are fused. And of course, this pattern of epidermal hyperplasia with hyperpigmentation is frequently seen over dermatofibromas. The proliferation itself has kind of hypocellular, lighter staining areas, and hypercellular areas. And if we look at the constituent cells at higher power, we can see that we've got these short intersecting fascicles of fibrocytes and histiocytic appearing cells, so that the cells have oval, fusiform, and spindle-shaped nuclei. There's a little bit of nuclear variability. A few of the cells are slightly hyperchromatic, and the amount of cytoplasm in the cells is somewhat variable, but certainly not mitotically active, and no zones of necrosis, nothing to suggest a malignant tumor. If we look out at the periphery, we can see that there's evidence of collagen trapping, very typical of a dermatofibroma, with the thickened collagen bundles surrounded by fibrocytes. What was unique about this particular tumor, and why I chose to highlight it, this proliferation, is you can see this deep dermatofibroma is extending into the subcutaneous tissue. And generally, you know, I found that when people are first studying dermatopathology, if they see a fibrohistiocytic proliferation extending into the fat, they automatically think, oh, this has to be a DFSP. But deep dermatofibromas, like DFSPs, can extend into the fat. The growth pattern of the two is decidedly different. With a deep dermatofibroma, what one sees is that the constituent cells, this fibrohistoacidic proliferation, tends to expand the fibrous septae in kind of a radial fashion. In addition, the tumor will frequently kind of compress the fat lobules, so it's kind of got this pushing border. You can see in this particular example too, we've got these lymphoid aggregates at the dermal subcutaneous junction. They're commonly seen in deep dermatofibromas with extension into the fat, especially at the dermal subcutaneous junction. Now let's go ahead and compare that with this slide. And again, bear with me as I tilt the slide here. This is a DFSP. And you can see that the growth pattern in the fat is quite a bit different. DFSPs, of course, give you that layering when the cells extend into the fat, kind of that layer cake look. And the neoplastic spindle cells in a DFSP intercalate between the individual's adipocytes. You can see them growing between the individual adipocytes and separating them. And again, this stands in distinct contradistinction to our dermatofibroma, which tends to compress the fat or radially expand the fibrous septae. So take home point, DFs can extend into the fat, but their growth pattern is different than that of a DFSP. So let's go ahead and move on to our next case. Case number 2. This was a little bit of a tricky case. We had an inflamed seborrheic keratosis, but there was evidence of early herpes simplex virus arising in association with the seborrheic keratosis. So let's take a look. Here, I'm going to flip the slide. And we have a trisected shape biopsy specimen here. You know, you look at the top piece, and this is pretty classic seborrheic keratosis. The cornified layer is markedly thickened by basket weave hyperkeratosis. The epidermis is gently papillated and moderately hyperplastic. The keratinocytes show evidence of orderly maturation without any atypia. This lesion has a very benign silhouette with a flat bottom, and we've got a lot of pseudo-horn cyst present. So classic seborrheic keratosis. But if we look at all three pieces, we can see that there's quite a bit of lymphocytic inflammation in these sections. And if we look at the middle piece in particular, you know, we're beginning to see some intraepidermal vesicles. Some of these have formed as a result of spongiosis. But if we look at this particular area of the epidermis, and I'm going to get my pencil here and kind of demarcate it, we can see there's this intraepidermal vesicle, but the keratinocytes in the epidermis look different. There's definite evidence of ballooning or intracellular edema as reflected by the pallor of the cytoplasm. And if we look at the nucleoplasm, we can see peripheral condensation of the nucleoplasm. These have the characteristic steel gray appearance of herpetically infected cells. We've got margination of the cytoplasm. This is pretty early, so we don't have multinucleated keratinocytes or much in the way of molding, but we definitely have viral cytopathic effect diagnostic of a herpes virus infection. And in this particular instance, application of immunohistochemical stains directed against HSV1 and 2 showed striking nuclear decoration of these cells, confirming the diagnosis of herpes simplex virus arising in association with a seborrheic keratosis. So one of the take-home points of this case is, you know, as a dermatopathologist or even as a dermatologist, never be pleased with one diagnosis. You know, if there's something that catches your eye in histologic sections, be open to the fact that you may have more than one process present in a given biopsy specimen. You know, I've seen desmoplastic melanoma arising in association with superficial basal cell. A lot of times we'll see a herpetic infection in a nevus, so you just want to be open to that possibility. Okay, case number 3, the correct diagnosis is Hidradenoma papilliferum. And again, I've got 2 slides on this particular screen. So let's go ahead and focus on the tissue on the left, because that's the sections that you had. And there clearly was a partially sampled epithelial tumor. It's extending to the edges here. And this was a dermal-based tumor. It's got a maze-like configuration, and it was composed of these elongated branching tubules, some with papillary fronding. If we look at the luminal aspect of these structures, we can see that we've got high cuboidal to columnar epithelium with evidence of decapitation secretion. So clearly we've got an apocrine tumor here. And if we look at the mesenchymal cores, we can see that there are fibrocytes, but there's really not much in the way of active inflammatory infiltrate within the surrounding stromal tissue. Very characteristic of a Hidradenoma papilliferum. This, of course, is a tumor that tends to occur in apocrine-rich areas, commonly on the vulva. Occasionally, you'll see them on the breast or on the eyelid or in the ear canal, and these tend to be deep. Now, one of the key differentials is another type of glandular tumor, and we'll take a look as soon as I tilt this, a syringocystadenoma papilliferum. Both Hidradenoma papilliferum and syringocystadenoma papilliferum are glandular tumors that show differentiation towards the secretory portion of the sweat gland apparatus. And like a Hidradenoma papilliferum, syringocystadenoma papilliferum is also characterized by these papillary projections that have a very similar lining, kind of this high cuboidal epithelium, and usually evidence of decapitation secretion along the luminal aspect. Syringocystadenoma papilliferum differs from Hidradenoma papilliferum in that, unlike Hidradenoma papilliferums, syringocystadenoma papilliferums are attached to the overlying epidermis. And so generally one can see a transition from stratified squamous epithelium of the epidermis to the more glandular epithelium. The second big difference comes from looking at that fibrous core, the mesenchymal tissue in the center portion of the papillary projections. It typically is stuffed full of lymphocytes and numerous plasma cells in a syringocystadenoma papilliferum. So generally, one can distinguish these 2 tumors quite readily. Now, another tumor that enters into the differential diagnosis with our Hidradenoma papilliferum is an digital papillary adenocarcinoma. And one can see in this biopsy from acral skin, very thick cornified layer, we have this dermal tumor situated in a portion of the dermis that one frequently sees hidradenomas. And this also has numerous papillary projections. But a digital papillary adenocarcinoma typically is much more cellular. The glands are more tightly packed, and generally one will see more nuclear pleomorphism, mitotic figures, and necrotic cells, although the degree of atypicality can be somewhat variable. One of the clues to the diagnosis, of course, is the anatomic location of this lesion. And digital papillary adenocarcinomas are most common on the fingers, and you're not going to see a Hidradenoma papilliferum in a volar location such as this. And generally, the teaching point with these digital papillary tumors is when you see a digital papillary tumor, you really want to assume that is malignant. They really should all be considered carcinomas, because the metastatic potential for these aggressive or digital papillary adenocarcinomas is quite high. Let's go ahead and move on to case 4. Case 4 was an interesting case. The diagnosis in case 4 was Morphea profunda, or subcutaneous morphea. This was an incisional biopsy. And on scan, one can see a superficial and deep kind of nodular infiltrate. Looks like it's composed largely of lymphocytes, small round blue cells. If we look at the dermis, we can see a broad zone of sclerosis and kind of a squared off biopsy specimen. And so, right off the bat, this looks pretty good for this zone for conventional morphea. And in those zones, if we go down and take a look, one can see that the sweat glands are kind of bound down, which is what we see in morphea with loss of the surrounding subcutaneous tissue. This particular variant of morphea is kind of an inflammatory expression. It's got a little bit more robust lymphoplasmacytic infiltrate. And one can see that the sclerosis in this case is extending into the subcutaneous tissue. And morphea, like necrobiosis lipoidica, when it affects the subcutaneous tissue, gives one a septal rather than a lobular paniculitis with sclerosis involving the fibrous septae. And one can see, of course, extension of the sclerosis quite deep, even down to and involving the fascia, of course, in cases of Schulman syndrome or eosinophilic fasciitis. Now, another consideration that one would want to have in this particular case, I did when I saw this case, is the possibility, especially if this is an isolated indurated lesion, of a desmoplastic melanoma. Again, when we see spindled cells in the dermis and these lymphoid aggregates, you always want to be attuned to that possibility. There was certainly nothing here along the dermal epidermal junction in terms of melanoma in situ. A MART1 stain was negative, and we went ahead and did S100 and SOX10 staining, and there was absolutely no appreciable decoration of cells in the dermis, kind of allowing us to exclude that as a possibility. But in any case, nice example of deep morphea with extension into the underlying subcutaneous tissue, producing a septal paniculitis. I did get one question here. Is this the same as a nipple adenoma? And I'm sure you were talking about a Hidradenoma papilliferum. Nipple adenomas are another type of apocrine tumor. They look a little different, close relative, but really kind of a different entity, okay? And the histology is a little bit different. Good question. Okay, let's go ahead and move on to case 5. Case number 5, the correct diagnosis is lymphomatoid papulosis type A. And this was an absolutely beautiful example of type A OYP. The epidermis is moderately hyperplastic. We've got a dense nodular infiltrate of cells in the dermis that's present not only perimascularly, but interstitial. And if we move to higher power, we can see we've got quite the cocktail party going on here. Within the dermis, we've got a lot of small, round lymphocytes. We've got eosinophils in number, a lot of neutrophils sprinkled about. But if you start looking around, you can see large numbers of these really atypical mononuclear cells. The nuclei are quite pleomorphic. Many are hyperchromatic. If you look around, you can begin to see in some areas mitotic figures. And these nuclei are very large. And a CD30 stain revealed striking decoration of these atypical mononuclear cells, confirming the diagnosis of lymphomatoid papulosis. Now, lymphomatoid papulosis is a condition that's in the spectrum of primary cutaneous CD30 positive lymphoproliferative disorders. And there are at least 6 different variants of LYP that have been recognized, the histology being quite variable amongst the forms. Type A, which is the type exhibited here, is the most common and characteristic with that mixed infiltrate of lymphocytes, eosinophils, neutrophils, and the atypical mononuclear cells. Type B commonly mimics MF. Type C can be indistinguishable from anaplastic large cell lymphoma with just sheets of atypical cells. Type D mimics primary cutaneous aggressive epidermotropic CD8 positive cytotoxic lymphoma. Type E mimics extranodal natural killer T-cell lymphoma, nasal type, and so as such it can be angioinvasive and angiodestructive. And then there's a recently described variant which is characterized by DUSP22 rearrangement. One of the take-home points of this case is that clinical pathologic correlation is key in the diagnosis of LYP. Of course, patients with LYP will present with these crops of ulcerated nodules and papules, most frequently involving the trunks and limbs. And they'll have lesions that resolve spontaneously, while at the same time, new lesions will erupt at other sites, trunk and limbs, again, being most important locations. But because of the marked histologic heterogeneity of the condition and its tendency to mimic other lymphomas, there's a real danger histologically of diagnosing the patient with a more aggressive form of lymphoma. And so before you make the diagnosis of LYP histologically, you want to correlate with the clinical history. It's particularly important, again, in the diagnosis of this condition and in most cutaneous lymphomas, so I can't stress that enough. Okay, and our last case, we should be finished in about 3 or 4 minutes. The correct diagnosis is Erythema multiforme. And you can't talk too much about interface dermatitis. We're going to focus on the slide on the left because that's those are the sections you had available for review. And one can see that even at scan that there's a superficial perivascular infiltrate. The DEJ is not real crisp, so there's clearly some blurring of the DEJ here. And actually in the central portion of the specimen of the bottom piece of tissue, there was an entrant subepidermal vesicle. And if you focus in on the epidermis in this area, there's extensive necrosis. There's quite a bit of ballooning or intracellular edema. There's a little bit of spongiosis, but all of this is occurring with an overlying basket weave cornified layer. If we look at the edge of the specimen, again, we've got vacuolar change along the DEJ, a little bit of a lymphoid infiltrate obscuring the dermal epidermal junction. And we've got clusters of necrotic keratinocytes within the epidermis. So a little bit of pigment dropout within the underlying dermis. So we've got lymphocytes and scattered melanophages. And these features are very characteristic of Erythema multiforme. So with Erythema multiforme, we like to see a basket weave cornified layer, vacuolar change along the DEJ in concert with necrotic keratinocytes in the epidermis and a superficial perivascular infiltrate of lymphocytes. Now I find the entity that causes most difficulty, and we've discussed this in other happy hours before, with Erythema multiforme is fixed drug eruption. And that's because, let me flip this again, the two can show very similar changes along the dermal epidermal junction. So over here, we've got a bisected punch biopsy. This is a fixed drug eruption. And as we zoom in, here we've got a basket weave cornified layer. While we like to see a basket weave cornified layer in the setting of EM, fixed drug, sometimes the cornified layer is basket weave, it may even be parakeratotic. If we look along the DEJ, once again, we have vacuolar alteration. There are scattered necrotic keratinocytes here within the epidermis, although we don't have the degree of epidermal necrosis, spongiosis, and ballooning in this particular example of a fixed drug eruption. And if we look at the inflammatory infiltrate, not only do we have lymphocytes and melanophages, but if you look in the dermis here, you begin to see large numbers of eosinophils within the infiltrate. And if you have an interface dermatitis with necrotic keratinocytes, and you're trying to distinguish EM from fixed drug eruption, if you begin to see eosinophils in numbers, it's a fixed drug eruption. It's not Erythema multiforme. In both conditions, you can get extensive necrosis, ballooning. You can get intra and subepidermal vesicles. And keep in mind with Erythema multiforme, if it occurs in skin of color, you can get a lot of melanophages in the infiltrate. So I think the singular most important discriminating features in distinguishing Erythema multiforme from fixed drug eruption are the number of eosinophils within the infiltrate. In EM, you should have a predominantly lymphocytic infiltrate, and in fixed drug eruption, the infiltrate should be mixed with lymphocytes, eosinophils, and melanophages. So that's it in a nutshell. Would appreciate any feedback you have. And again, if you need clarification on any of these cases, if you're watching it live or watching it later, please feel free to reach out to me. Thanks so much and have a good day.